record button or the broadcast button or whichever it is. Record. There we go.
Yeah, it's just switched on now.
Great, marvellous. Thank you very much. Okay, so welcome everybody. We've got some apologies today. So the ones that we've been notified are from William Lee, from Hein, from Mark Burgess, Jason Stokes, Peter Taylor, Bill Borrett, and Sally Watson. I don't think we've got any more. So if we could note those, that's good. Thank you. I haven't got any specific chairs action to update you on, so we can move swiftly on to the other item. So I don't think we've got any declarations of interest for today's agenda over and above those that are already registered. Just check that's the case. Okay, that's good. Thank you. So that takes us on to the minutes and the action log from September. So I'll go through the minutes just in terms of accuracy first. So I'll take a shout as I go through if there are any issues. So I've got page 1, page 2, page 3, 4, 5, and 6, 7, 8, and then 9 and 10. So people happy that that's an accurate record, we're able to get those signed off. I'm seeing some nods, that's great. Okay, thank you very much. In terms of the action log, let me find that. Sadie, can you navigate us through this?
I'll do my best. Yes.
Thank
so
you.
for action 153, we suggested that we close this action and move it to the forward planner, because the request was for a further update on the shared care record implementation through the digital report. So if members are content with that recommendation, we can close that one.
Yep. Thank you. Yes, I think we're content with that.
Great. Action 164 was the performance report. This is for Shepherd. I am just trying to remind myself in my memory. We do have a draft, I think, for that report, but in the first instance, it's going to be heard in private, so that members can consider the information and we can decide how we would like to report that in public going forwards. Okay. So I think we can complete that one.
Yep, thank you.
Action 165, the operational delivery group report. The general practice one is on the agenda. Unfortunately, the dental one was slightly out of sync, so that will come to the next meeting, but I've tried to include some more information on performance in the report, so I would suggest that we close that and we can pick up any new actions under that item.
Okay.
The next one is done around the minutes. Action 167, that's proposed to come back to the December meeting. If people are content, we can close that and add it to the forward plan. And then the final action on there's a very long update, comprehensive rather than long, I should say. If members are content, we can close that action because it's been addressed quite fully.
Yep, very helpful. Okay, I think we're content with that. That's great. Okay,
Thank you.
that's good. So that takes us on to the forward plan, doesn't it?
Yes. So as you can see, further to agreement at the last committee, the November and January meetings have been cancelled out there, and the content planned for those meetings has been moved across so that we don't lose it. So next time when you see a version of this, we'll delete those from the plan. We've continued to work on this as we've look to manage activity across the operational delivery groups and the committee. However, the only thing of note today is the terms of reference review, which is in the spotlight section, and we are not hearing that today simply because it doesn't quite fit within the timings of the approach to this. So we're proposing that we defer it until February and come back to it then. And as you can see, we've popped it to be confirmed into the February meeting, just in case it doesn't quite make it. That is something that is managed through the corporate governance team with our input.
Yep. Okay.
Otherwise, I think we're pretty on plan for today.
Okay. Excellent. All right. Okay. Anything anybody wants to add about that? Anything missing? Anything? No. Otherwise, I think that all makes sense and fits with what we've agreed before. So that's great. Okay. Thank you. Perfect. Okay. So just juggling my various screens here. So that takes us on to item 6, which is the joint forward plan. Is that right, Sadie?
Yes, that's right. And Sarah in my team is going to present that, Debbie.
Great. Okay, Sarah, over to you. Thank you.
Thank you. Hello, everyone. To those of you that don't know me, I'm Sarah Harvey, Head of Strategic Planning for Primary Care here at the ICB. So just want to give you a brief update on the progress against the primary care joint forward plan ambition and objectives that were published in July earlier this year. So just as a reminder, the primary care ambition was developed in consultation with both patients and system partners, and outlines the aim of integrating our primary care services to deliver improved access to care closer to home for patients. We developed 2 objectives for 2023 to 2025, which are developing our vision for providing a wider range of services closer to home, improving patient outcome experience, and specifically an objective around stabilising dental services through increasing our dental capacity in the short term and developing our plans for the next 5 years. So I've included some key progress updates within the body of the report. I'll just run through a few in that we've developed our outlines, milestones in terms of our strategy development, which both the dental strategy and the general practice strategic plan will be developed by March 2024, and work is already ongoing to deliver that. We're working closely with our population health colleagues to develop the data that's necessary to support those, underpin those plans. And in relation to integrated neighbourhood teams, we've worked on our definition as a system in what does this mean for us, and moving towards the term more integrated neighbourhood working, which better reflects the work currently being undertaken by locality teams within the ICB. In relation to dental services, you'll all know that our dental short-term plan has been signed off and approved, and the work is well underway to developing our longer-term dental strategy by the end of March 24. And then just to highlight the upcoming milestones for October through to March, which is around further engagement with our local population and system partners, and then the development of those 2 strategic plans. So the paper is just for noting, but I'm happy to take any questions if anybody has any.
Okay. I'm interested in the the engagement with the population. What's that's you know, specifically targeted, or is it a general sort of engagement about how is it feeling?
So there's kind of both. So we work really closely with Health Watch, and we've got a lot of engagement routes already set up there to engage with the population. But I've also been working with our population health and health inequalities team around whether we can do some more targeted engagement with within using the Community Voices programme to reach out to those harder to reach communities and hear what they would like from our strategic approach.
Okay, all right. It'll be good to get some feedback on that, I think, to hear that.
Okay.
Okay, and anything else for Sarah? No. Okay, so I think we're asked to note what's happened so far and to look at the milestones coming up. So that's great. Okay, thank you very much. So that leads us then to the primary care recovering access plan. So a neat follow on, I feel, so a bit more detailed granular information. So is this you again?
Yes,
Sarah?
this is me again. Thank you. So in response to the national delivery plan for recovering access to primary care, all systems are asked to develop a system access recovery plan, and committee members have already seen a version of this in private, so we are bringing this through the public meeting. Worth noting that the version of the plan included is still currently work in progress, and the ask from the group is around support of the direction, and noting that due to the timings of meetings, there won't be a further meeting to share in a version of the report with committee members, but I will do that virtually, and it will be taken through our general practice operational delivery group for further discussion before submission to the board meeting in November. So I'll just give a really brief overview of the plan as it stands. So the kind of ambition and approach and vision is outlined in the context of, as we've just spoken about, our ambitions outlined within the joint forward plan, and building on showing a strategic alignment to other system and national plans, and also how this links to the fuller stocktake report, which was published last year, which outlines the vision for integrating primary care. So the vision's been developed in that strategic context. The plan also encompasses the commitments from our PCNs that were developed in line with their PCN capacity and access improvement plans, and then highlights how we plan to deliver this using all parts of our system, so within the workforce team, the digital team, commissioning team, and various partners across the system. We've included some of the drivers for change in both a national and local context, including some of the results at a system and PCN level from the GP patient survey, and how we plan to monitor the delivery of this plan using data, and how we'll work with our PCNs to do so. The plan outlines our approach in line with the 4 national asks within the plan, so implementing the modern general practice, building capacity, cutting bureaucracy, and empowering patients. I think it's worth noting that, and it's clear from those that have read the plan, that there are still areas for further development, and there are placeholders in there, and we've been working with colleagues to get their feedback, so all stakeholders from within the system, but also our colleagues at NHS England, to get their feedback on the plan as it stands and where they feel that there needs to be further development. We had a really positive meeting with NHS England last week, where they felt that we'd really clearly articulated our vision, but there was still work to do in terms of what does this mean for Norfolk and Waveney in 23-24 and then beyond. Worth noting that we are working on including some more information around the support offers that are in place and how we can provide some funding, transformation funding, to support PCNs and practices to deliver the change. I'll stop there and I'll open up to questions, because I appreciate there's a lot of information within the slides and report.
Okay, thank you. So who wants to kick off? Ian.
Yeah, thanks, Debbie. Thanks, Sarah. As previously commented in email on a restricted basis, really good with the way the plan is developing. A lot of good stuff in there. So much more detail than the first draft. So thank you, Sarah. Thank you to everybody who's had an input on that. I suppose the only thing I'm a little bit unsure, given we're sat here halfway through October, is how the further iterations are going to be developed and undertaken before that public meeting on the 28th of November, I think it's scheduled for. Now, the secondary question to pick up on that is I understand that's a face-to-face meeting rather than Teams. There's no further detail on the ICB website, so if there can just be some more detail, please. But you know, if it can be expanded as to how that is going to be presented, that would be really helpful.
Sorry, and I don't know if it was just me, but you cut out partway through. Are you asking about the board meeting in November?
Yes, please, if we can have details, because it's face to face on the website. So more details and who will be presenting. And the first part of the question was how further iterations are going to be developed and, if you like, shared before that meeting.
No, that's great. Thanks, Ian. So as I said at the start, I will be sharing kind of live working drafts as they're updated, and the version that we propose to present to the ICB board will be shared with PCCC committee members virtually for any final comments and feedback before that is submitted to the board meeting. With regards to the actual board meeting itself, I'll have to come back to you on that one offline, Ian, because I don't know the detail of that at the moment.
That'd be helpful. Thank you.
Yep, thanks, Sarah. Karen. Thanks,
Debbie. And just wanted to congratulate Sarah. It's a really well-written piece of work. It's really good to see the standard of work here. It's phenomenal. Really exciting, really sets out the plan. We have spoken before about the links into quality and quality improvement. We just need to make sure that we articulate that within the next iteration of the documents, just to make sure the improvement is there. Thank you.
Yeah, thank you, Karen. Really appreciate that. And I've reached out to Evelyn about that already.
Okay, thanks. Sadie.
Thank you. I think it's worth probably just reiterating that nationally, NHS England have 3 priorities. So we have urgent and emergency care, we have elective recovery, and we have this priority for primary care. So there's an awful lot of focus on this work from NHS England, quite rightly. And we did have our first assurance meeting, I think it was last week, might have been the week before, on this with NHS England, which was a really positive meeting and has given us lots of helpful pointers on areas where they would like to see slightly more information. For example, being really clear about what our priorities are and what impact they're going to make. And also Sarah has been leading and coordinating a piece of work around demand and capacity modelling, which is really exciting. And so it's been suggested to us that we include some more of our numbers in the plan, for example, and as part of our operational planning requirements, we had to set out commitments for appointment numbers, LD health checks, and so on. So they will all become a feature of the plan. I think clearly we will want to consult the LMC in an official capacity on this as well, and I think we'll need to do that while we're going, recognising that I think this plan will stay quite live, and I would imagine that even after the November board meeting it will continue to remain quite dynamic, because that's how things work in primary care. But I agree with comments already made. It's a super piece of work, Sarah. Well done for coordinating it. I know lots of people have contributed to it, and look forward to seeing it as it continues to develop.
Thank you, and I just thank you to all my colleagues that have helped the development of this as well. Couldn't have done it on my own.
Okay, I wonder if I might just so on the placeholders where we've got in the presentation, so the first placeholder that's at number 12, so that's entitled data. So forgive my lack of operational sort of understanding of this, but when we're talking about operational planning submissions, the things you've got in there, what will that actually give us? What will that tell us in there?
Yeah, no, absolutely. So I think it kind of goes back to what Sadie was just saying in terms of what we've committed to deliver as a system already. Okay. But some of the work that we're doing, so particularly around LD health checks, I know there's a huge amount of work ongoing already to try and improve those. So it's to try and it was kind of like a one placeholder, but I think it covers a lots of things. But I think it's about what we've committed to do, what we're doing to support that, and then how we see that kind of moving forwards in the future. So it's a kind of 3-step placeholder, and as Sadie said, it will develop over the coming weeks.
Yeah. Okay. So in terms of sort of our role in monitoring the delivery against this, that's what we'll be looking at as we move into next year. Yeah.
Yes.
Okay. All right. Okay. I don't know, what capacity there is, but I do think it would be great to be able to translate this into, a public-facing document, actually, that residents can understand. That actually says, here's our vision for it. This is what we're trying to do. Yeah. Here's your part of the deal. Use these things because actually that helps your practice. Just some sort of work around that, I think, and maybe that's something that Health Watch could support us in. I just think that would be really helpful.
Yeah, no, I completely agree, and I think that's really useful. Thank you. And we're planning to use this plan as the start of our kind of more strategic plan for general practice. So it will probably, as Sadie said, it will probably become one and the same document that evolves over the rest of the course of this year into our more strategic plan for general practice delivery in the future.
Yeah. Great. Okay. All right. Well, we will, heartily endorse what others have said about, the detail and the clarity of this, Sarah. So thank you to you and your team for doing that. And I think that, helpful to understand that, between now and when it comes to board, there'll be a bit of iteration and some, continued engagement about that. And I'm sure as soon as the arrangements have been made for where the meeting is and what those are, we'll make sure that the committee is aware of those. Come along, join the audience. That would be amazing. That would be really good. Okay. All right.
Thank you.
Brilliant. Thank you very much. Okay. So so this is, I mean, brilliantly planned agenda, because obviously, a key element of this is actually, getting and retaining staff, isn't it? So what we're looking at now are the workforce issues themselves. So who am I talking? Who's speaking to this one?
That will be myself, Debbie.
Excellent, Jade. Welcome.
Thank you. So I have taken the paper as read. I would like to highlight a couple of key things for the committee. Obviously, the main thing is to highlight the workforce plan, education and delivery plans, and the actual operational detail is obviously featured heavily in Appendix B. So that will give you that granular context if for committee members that would like to know the ins and outs of every single program, that's the document to refer to. But for today, the purpose I think which is quite helpful is what I'm looking for approval is Appendix A, which is actually showing through the workforce pillars, the targets. So that will really give the board an overview of all the strategic pieces of work that's been happening within primary care workforce and the targets that we are aiming to achieve by the end of this financial year. It also highlights within that document where we've got a national target to meet as well through the Primary Recovery Plan. We also have a training hub contract in place with NHS England within the ICB, but we've also put our localised targets within that measure. So that would be another document, particularly for today, looking for approval on. The other key features within the report is showing our external bidding. So my team have done a fantastic job in trying to bid for external funding. So we've so far, the figure is going up, but so far for the report for today, it's 504k we've bid for external funding. And I'm pleased to say 46% of that funding has been successful so far. We're still waiting on outcomes of the rest. So they are doing a fantastic job. We've actually just submitted a few other bids this morning. So hopefully we'll be able to update PCC with further details. Now, all of those programs would help support workforce initiatives. Some are very focused towards general practice, community pharmacy interventions. We're looking at wider sector CPD training because I just wanted to highlight to the board, we only receive funding for general practice, workforce initiatives and training. So where we try to look at other external funding bids to cover the other primary care sectors. The other highlight I want to talk about, which I know the board was very keen about the last committee, was a health and wellbeing. So within the report, been working with our fantastic BI team to help produce a health and wellbeing dashboard, which has really been quite useful in planning the pieces of work that we want to complete for this year. The key themes coming out of that would be burnout, harassment, particularly from the public, harassment, and also stress. So there are health and wellbeing initiatives being put in place. Some are launching this week, called a Working Well, a 12-month program to help combat that stress and that burnout with helping support our primary care colleagues, which is available to all of primary care workforce of the 4 sectors. So happy to take any questions.
Okay, thank you, Jade. So the Appendix A that's got all the detail in there, there's a I mean, that is, you know, very comprehensive, isn't it? I just wonder, before I bring Karen in, you know, are there, I guess, you know, this is, you know, from where I'm sitting, I'd find it helpful to get a sense of actually what you think, you know, the scale of what we're trying to achieve there is. Is this what you would expect incrementally every year? Are we stretching ourselves? Are there particular elements and lines in here which you would say we've really pushed the boat out on this one? You know, that sort of a guide I think might be quite helpful.
Yeah, so all the targets set out is an increase from the previous year.
Right.
In terms of what we're trying to achieve. There are some new initiatives being put in, particularly if we look at the ST3 incentive to attract newly qualified GPs within Norfolk and Waveney. That's been the first year that we've piloted this. It's very successful. We've already recruited 25 newly qualified GPs as a result.
Right.
So that's a new initiative
Right.
that we've brought in as a result. We're building on some of the other programs. So our health and wellbeing programs, this is really fed by the intelligence that we're getting from our professionals, our frontline, non-clinical and clinical professionals, about what support and resources we need. So a lot of it is data driven. We're looking at obviously the overall workforce portfolio and things like that. But generally, all the programs put in place are an increase from the previous years.
Okay, right. And I suppose, just again, sorry, Karen, for you in, you know, I suppose just the obvious thing is that actually it keeps ahead of the sort of the rate of people of which are either moving out or leaving. So it gives us an overall gain. Is based on trends, does it? Yeah.
Absolutely, yeah. So we will look at that based on what's coming through, look at where our areas. So, for example, our GP partnership model, we've continued that locally because the national program has stopped. So we know that's an area that we would like to increase our partnerships across Norfolk and Waveney. So we have specific focuses of programs based on geographical need and based on what the information is presenting to us, but also working with all our primary care networks and all our practices across Norfolk and Waveney for all the sectors that we've got.
Great. Okay, thank you. So I've got Karen and then Andrew. Karen.
Thanks ever so much, Debbie. Thank you, Jade. It's really, really pleasing. I sound like I'm at an award ceremony today, but it's really pleasing to see the maturity of this work, having been there at the very early days when the hub started. And just to see how you're still striving and you're managing to get the funding come through, because in times like this, it's nearly impossible, isn't it, to get any funding. So congratulations to yourself and the team for that. I guess for me is the question is, what feedback are we getting on the schemes that we've got in place? Because it's been, hugely successful, but I'd love to hear what other people are saying. And is there anything more we can add to that suite of offer to support the GP workforce? And just to add to that, is there anything more we can do around pharmacy? Because it was pleasing to see you've got some funding to support pharmacy training for dispensers. But given the shortage of pharmacists we're seeing at the moment, we need to really be thinking about that, and dentists too. Thank you.
That's okay. To answer your first question, a lot of the programs that we've put in place have been in partnership with practices. So we've been working very collectively together about what their needs are. Obviously, this is all fed through from the training needs analysis, which we started off in general practice. We've just closed dentistry, optometry, and pharmacy will be going out from Q4 because of some of the working with the LPC, obviously the local medical committee, and obviously the LDC. So there's a number of factors and stakeholders that we work collectively together. It is face-to-face conversations as well with the practices based on what their challenges are, and a lot of them are very similar. So where we can pilot something that's worked quite successfully, we can then roll that out. That will benefit a majority. So there are a number of things that we do for that. In terms of the funding that we get and how we can support the programs, absolutely, I would love to be able to do a lot more within the envelopes that I've got. So we will continually bid for funding as and when we can. We're hoping that the contract that we've currently got in place will cover all the 4 sectors of primary care, but at the moment, the funding we receive is limited to general practice. But that doesn't stop us to go for bids, which we've demonstrated already. We obviously will review the programs we've got for community pharmacy. I've coming back into part 2 of PCCC to look at dentistry workforce programs and things like that. So there are things happening that we're looking to do, but absolutely we'll continue to make sure that all of our sectors are being represented as much as we can.
Right, thank you. Andrew.
Yeah, thanks, Debbie. Hello, Jade. I just wanted to, this ties in a bit with Sarah's presentation as well, but from a Health Watch point of view, to share with you some of the feedback that we get from both formal feedback and just conversations as well, really. And I think there's a bit of work to do yet on educating the public on the changes. Because I really think if you were to speak to people random in the street and talk about care navigators and physician associates and first contact physios and so on, most people wouldn't have heard of those roles and wouldn't know the difference. And the conversations I have time and time and time again, I'm afraid it goes back to the previous setup. I just want to see my doctor again and again and again. And we know and understand that things are changing and the reasons behind that. But if you want to take the public, or if we want to take the public with us, I think there's an awful lot of communication yet to do.
Yeah, absolutely, Andrew. I agree with that. So I am working with our comms team, particularly going out to different practices, trying to do a marketing campaign for the public to see the different roles within all the different sectors, but also for the recruitment as well. So we're currently building that in with my current plans within this forecast, and obviously we'll continue working with our communications department to get that campaign, that public-facing campaign about all the different roles. They are featuring on our social media channels, so it comes out quite regularly on terms of that. But I think, as you said, it's that continual cycle to educate the public about the different roles that we have and the great vast of practitioners that we've got across Norfolk and Waveney and what they can actually do for the public.
Yeah, great, thank you. I think we really need to at some point, we really need to notch that up, because just remember that the people that your target audience don't follow you on Twitter.
Exactly. Yep. All different segments. Thank you.
Thanks.
Sadie.
Thank you. I am really conscious of what Andrew has just said, and yes, the support primary care campaign is a feature of the access plan. But I also share your concern that it's just not getting the reach necessarily that we want it to. And I mean, I've been around long enough to remember when nurse practitioners were first introduced into general practice teams, for example, and people didn't want to see a nurse, they wanted to see their GP. And so I would really welcome the input and insight from Healthwatch actually on this, and thinking about how we can get these messages to land better, I suppose, and how we support people to trust the other health professionals as part of the team and understand that, you know, you're going to be matched to the person most suitable for your needs. And how do we help people to trust that process, and how do we get the messages right, and where do they need to go? Because you know, there's enough will here from the ICB. The comms team have done some great materials, but you know, it's not a short-term thing, is it? It takes a long time to permeate, I suppose.
Yeah, I think that's right. Hilary.
So I'm in danger of just agreeing, to be honest. Sorry, I'm late to the meeting because I've been doing clinical work this morning. I've only just escaped from that. But we've had paramedics turning up at people's houses that they've refused entry to because they're not GP. We've had our nurses shouted at because they've recommended an FCP appointment rather than a GP. So people just don't understand. And I think sometimes it seems they will only take it from a GP that it's okay to see somebody else, it seems. And also increasingly we're getting people who are unhappy with the waiting lists at the hospital that will only speak to a GP about it because they're the only ones who are considered to have that knowledge, whatever, oversight, whatever it is. But yeah, so the number of things that only a GP can satisfy people for seems to be increasing, and obviously that there's an opportunity cost to that because we're not seeing some of the people that actually really do need to see us, and we're ended up seeing people that are very unhappy but could be dealt with by somebody else.
Yeah, okay. Ian.
Thanks. Just reiterate exactly what Andrew and Sadie have said. To me, this is one of the big problems in the NHS at the moment. Not least because, unfortunately, there is political capital to be made here. Only yesterday, Keir Starmer was standing up on stage and, if you like, backing that public perception that only GPs are good enough. I don't want to make a political point, but absolutely what I would say is we need to be on the front foot as a system and to make sure that we are providing the public with the message that needs to go out there, comes out from NHS England, and basically is counteracting the other side of the argument, which is being put across by many different quarters. What I would ask the ICB to be considering is best practice nationally. There are other areas that are probably ahead of us on the curve in getting public buy-in, and it would be really good to make sure that we are picking up on best practice and explaining to the population of Norfolk and Waveney all these good new roles, the benefits of seeing somebody who has specific expertise to what they are needing rather than the general practitioner. So that's just a point picking up the vast array of messaging that is going to the public to the contrary of what we've just been talking about.
Okay, thanks, Ian. James.
Yes, thank you very much. And I didn't put my hand up as soon as Ian said something political, but and Ian has actually said quite a bit. And really, this is a question for Hilary, if I may, Chair. Sometimes a GP is not the best person to see. Is that right? And how can we get that message across? Because I've just put that on the table a bit contentiously, but I think I saw Hilary smile, so that was all right.
Yeah, no, if it's okay, no, absolutely. Sometimes I am absolutely not the best person for somebody to see, and I have somebody who is the best person, but somebody doesn't want to see them, so it is tricky.
Yeah. Just before I bring Lisa in, I did wonder, James, if you were going to talk about, maybe the reach that locally elected councillors have. If I think about, I suspect I'd probably wince if you told me how many parish councils you attend in a month, but that sort of grassroots, engagement with people who are movers and shakers and opinion formers in their communities. It might be that actually there is something about equipping, our elected representatives, our other sort of, organisations with those key messages to get out there as well. I think it's not just about the ICB putting stuff out there. It's actually about the word of mouth stuff and people's experience, isn't it? So that might be something that we want to think about.
If I just come back on that, because I'm very, very happy to do that, and just so that colleagues know, I'm lucky. I've only 2 parish councils, but some of my colleagues have up to 24.
They absolutely do.
But no, that is an area that I necessarily hadn't thought about. But if we can get that some sort of information out via that, that's could be useful and certainly offer. Thank you.
Yeah. It is a bit of a generational thing as well. These things, take a long time to turn around, but that doesn't mean we shouldn't, start really. So I think I saw Lisa's hand and then back to Andrew.
One thing we need to remember that there is a responsibility for the individual practices to communicate it through their own comms. As a former practice manager, it should be communicated when the patient contacts the practice too, through effective signposting and triaging. And that's where you need to build the initial comms, actually making the patients of the practice understand what staffing are available at the practice. And that is also where you could bring in your PPGs to support that.
I guess sometimes at the point at which sometimes I'm guessing here, but the point at which someone's engaging with the practice, they're so it's almost the wrong time to be saying those. But I think what you're saying is that actually at the point that that ongoing communication with the people on your list, sort of thing. Okay. Andrew.
I just wanted to give you an answer really as a sitting parish councillor.
Okay.
In that I'm sure parish councillors would welcome input and to help. It's not a direct responsibility, obviously, but it's the sort of thing that people are happy to represent their local residents to the system, so to speak. And just as an illustration, we did exactly this. We organised a meeting here with our local practice, which has been having some difficulties, and embarrassingly, of course, is my own previous practice. So I had 2 hats to try and wear there, but it does work, and thanks to the practice manager who came and answered a lot of questions, it works well with the local population. We got over 100 people in a small village to that meeting, so I would encourage that as a way forward.
Okay, all right. I mean, maybe Jade, we could pick up this outside and think about actually what it might take and what resources it might take to be able to direct perhaps some of the marketing in those areas, but recognize that you know you've got quite a lot on here. So I don't think I've got any more hands. That was a really helpful discussion. Oh, Sadie.
Yeah, I was just going to suggest that that action's probably better sitting with someone else as part of the campaign work. So I'm quite happy to pick that one up and link in with others as appropriate.
Great. All right. Okay, that's good. So we got there from looking at you know, the detail around this, and I think the fact that actually we moved on to the other stuff is testament to actually what you've done here, Co. So thank you very much. And are you asking us to approve this, or are we noting
That's correct.
it? I can't remember.
Asking you to approve Appendix A with all the
Appendix
targets, please.
Yeah, great.
You.
Okay, so I think we're happy to do that. Few nods. Yep, we'll take that as read then. Thank you. Okay,
Thank you.
Marvellous. Okay, right. So where are we up to now? So that takes us on to operational delivery group report. Where am I looking here?
That's
Is
me,
this you?
Debbie.
Okay, great, Sadie, thank you.
Yes, thank you. So members will note that we had cancelled one meeting, so you've got one meeting's worth of update here from only a couple of weeks ago. It was another really good meeting. It's only the second one, so we're still learning as we go. We had quite a full agenda, but we did spend quite a lot of time talking about the work that's ongoing around trying to improve the uptake of learning disability and severe mental illness checks. And as you can see from the report, we are slightly behind where we would like to be in both of those areas. I think there is confidence around learning disabilities that the activity will begin to pick up. Certainly traditionally that's what's happened. It's been fairly low in quarters 1 and 2 and then picked up in the second half of the year, but due to the trajectory that NHS England agreed with us for our performance, it does mean that we are slightly off trajectory at the moment. There's a huge amount of work ongoing, and we have set up a meeting offline just for information for members to start to test alternative provision of health checks where we know that practices are struggling, for example, due to capacity issues. So that will come back for further discussion and approval at some point in the future. The SMI health checks are managed in a slightly different way in that they're looked at as a rolling average, a 12-month rolling average, and the latest data told us that we were at around 50%, which is again fairly consistent but behind where we would like to be. And we talked about the current ways that we fund that and whether there may be opportunities to look at this with the local medical committee in future, recognising that the locally commissioned service has another year to run. For SMI though, there are 4 practices with a large register, and so they are going to be targeted to see if they would like more support with the locally commissioned service delivery, and it's felt that that would make quite a significant difference. Looking at the data on SMI, there are also potential easy wins where patients might have been seen, but not every element of the check had been recorded. Might have been done, it wasn't recorded. So again, there are small things around data quality that we will be looking at. We also looked at the access recovery plan that we've seen here in an earlier iteration. That was very helpful to have some of those really detailed discussions. Check that the sort of discussion was reflected in the latest draft that you have seen today. And we looked at a latest CQC inspection report, which was for the Humble Yard practice, which has been rated requires improvement and is engaging doing lots of work, engaging fantastically well with the support that the ICB has made available. So in terms of approval, the only item that we approved was the locally commissioned services document, which had been developed with input from the LMC, and that just kind of really clearly sets out what process reviews will go through. I think it's a very helpful document for us operationally. It's very clear.
Okay.
So there wasn't anything as such to escalate to committee today, other than the ongoing risks around resilience for both general practice services in this case, although we've got dental services on there as well. Yeah, so that's probably about all I can say.
Okay.
I don't know if there's any questions from anybody. Have we got it a bit better this time? Is there more that people would want to see?
I mean, Ian.
Yeah, to me, you've summarised it very well, Sadie. It was a really useful meeting. Good stuff came out of it. Good cooperation between ourselves at the LMC, ICB. It seems to be working well. You raised one point in your summary that we are still looking for clarification on. And if I can pick that up with you offline, probably best, but it's around the alternative provision, bearing in mind that the LD health checks are a nationally mandated DES, but I think that's not one to trouble PCCC this afternoon. We'll pick up offline if we can. Right, thank you.
Okay. Otherwise, it feels as if you know the summary you've given and the issues that were covered seem entirely appropriate to me. And you know, note the sort of the 6-month update on resilience. I think that would be helpful as well. Okay. All right. Well, thank you very much. That's great. Okay. So where are we now? So we're now on. Yes. Practice manager attendee recruitment.
That's me again.
Excellent.
So this paper, I'm hoping, is fairly self-explanatory.
Yeah.
As part of our terms of reference, we have a vacancy for a GP practice manager as an attendee of the committee, a formal attendee. This is a similar process to what we went through before. The most notable change is that as a result of the remuneration committee agreeing the dental attendee, apologies, the role is going to be named as a specialty advisor, which brings it in line with the review that Frankie Swords undertook to all our clinical and care professional leads. So in the pack, you'll see the proposed comms and the proposed job role description, and subject to it making its way through the internal processes in the ICB for vacancy management, etc., and subject to agreement today, we can move forward with this as quickly as possible, albeit that the dates that we've set out are dependent on all of the governance stuff internally happening smoothly.
Okay, thank you. I mean, it seems a great addition to me, you know. Any other thoughts? Otherwise, I'm assuming people would be supportive of this. Yep. Okay.
Thank you.
I think we could take that as read then. That's great.
Super.
Okay. And then, okay, so then we're on to self-assessment and the contract assurance framework. So from memory, this is, again, comprehensive. Is this Shepherd or is this you,
Fiona?
Fiona,
Fiona.
excellent. Okay.
Thank you. So I will take the paper as read, but we want to take the opportunity to introduce primary care commissioning committee members to this assurance framework. It was in place last year to cover general practice, but was extended, obviously in light of the expanded responsibilities we now have for pharmacy, optom and dentistry services. We will be asked to submit a final submission in April, we now understand, but this report sets out what the framework looks like and the work that's currently underway to provide that assurance to NHS England that we're doing what we're meant to be doing under the delegation agreement. It is supported by quarterly meetings with NHS England regional colleagues, and we had our first meeting last week, which was very supportive. And the only other thing I wanted to highlight is that whilst we obviously have a very important relationship with Herts and West Essex ICB around the delivery of pharmaceutical and optometry matters, it's becoming increasingly clear in the past month or so that there is an increased workload for us directly as an ICB developing around pharmacy and optometry commissioning matters, which have not been resourced. So we need to be able to manage those within the primary care commissioning team as they are emerging. But I'm happy to take any questions.
Okay, I'll open it up. Reflections, comments, questions? Okay, I mean, you mentioned that the first sort of assurance meeting went well. You know, were there any areas that actually, you know, aside from the one you just mentioned, other than that, where you felt actually, you know, there was work to be done, or?
I mean, NHS England were extremely supportive. I think the first 6 months have been challenging, no doubt about it. First of all, us understanding and getting to grips with what we need to understand around these new services. I suppose the transition could have been smoother than we'd hoped, and we've been managing a lot of issues around that. But from a delegation perspective, you know, we're really pleased that we've got this opportunity to make a difference at local level. But there's no doubt at all that the resources we've got within the team and across the ICB, it's going to be a challenging workload to deliver. But I think in terms of assurance, we can provide NHS England and obviously this committee with that assurance that we're doing what we can.
Okay, all right, well, that's really good to hear, and a testament to all of you actually, because a small but perfectly formed team, I feel, is you know what you are. Sadie.
Yes, it was really interesting actually that this is sort of true matrix working in the ICB. So the assurance framework touches on lots of different areas. So we had colleagues from many different teams around the table because they all contribute towards the work that we're doing. And I think that was reassuring to NHS England as well. They were very prepared to listen to our challenges as well. So, for example, Jade mentioned that we don't have any funding for workforce as part of the delegation for dentistry, community pharmacy or optometry. And so NHS England were very happy to take issues such as that away to escalate nationally, which was really helpful. So, you know, it does feel very much like we're working in partnership and that we're all learning as we go here. So, yeah, it was a really positive meeting, and the team did a really, really good prep for it. So I think it went very well.
Yeah. Okay. All right. Well, that's great. Thank you. Okay. So I don't see any other comments on that. So again, this is one, Fiona, that you're asking us to sort of, you know, note to.
Yes, so we're asking the committee to note, obviously, it forms part of the assurance role that the committee has for delivery of the delegation agreement and what we're doing to achieve that across the ICB.
Yeah. Okay. And so did you mention that it comes that you do another visit?
So we will bring the full submission to this committee before we actually submit it to NHS England, and that will be for approval.
Yeah. Okay.
Towards the end of the year.
And I presume, I mean, do NHS England give you, you know, feedback, or any formal feedback?
Yes, they do.
I'm presuming they don't rate you, or there's nothing like that, but you know, you get something, do you?
Yes, we do. We receive feedback, but the first meeting, as Sadie has said, was extremely supportive, and it was more about how they could help us and escalate issues.
Okay. Yeah. Good. Quite right too. Okay. All right then. So I think we're very happy to note that and to thank you and the team that took part in that, and you know, bring it back when you're ready. That would be great. Thank you. Okay. So I think have I missed item 12? Is there a 12? Can't see a paper for that. Or is it just, no, we're actually on the finance report. Okay, so it is 12. So James, is this yourself?
That is, yes. Thank you, Debbie. Right. Yeah. So as usual with the finance update, I'll treat it as read, but just point out some of the key updates to the committee. So as we move into month 5 of 23-24 financial year, the ICB is currently forecasting an overspend of £3 million across across the prescribing, primary care and pod areas for the full year. This is actually an improvement in forecast variance from month 4 of £900,000. So we are showing some improvement as we're going on in the year. Moving on to the financial summary that's included in the pack, this shows a breakdown of the total overspend, which is in sort of 3 main areas. Firstly, the GP prescribing. This is currently showing £2.8 million overspent. £1.8 million is due to unidentified efficiencies within that balance, and then the rest is due to a reduction in our prescribing rebate for Edoxaban and other NCSO cost pressures. There's also some additional cost pressures around oxygen costs, particularly around the claims that patients are putting in for electricity costs. Again, something we've seen for quite a while and is continuing to impact on those costs. The third key area is within delegated co-commissioning. That is due to contractual underfunding, which we've seen in this area for several years, and some additional pressure around dispensing costs. This is partly masked by the LCS adjustment, and is showing as a £1 million pressure after that adjustment. The next sections 3 to 5, detailed variance analysis, that shows the major variances discussed for, but in more detail in those major areas. And then moving on to section 6, the dental section. This breaks down the key dental expenditures. You can see the forecast here is now £0.2 million overspent, which is explained by an offset of salary budget within our primary care cost centre. However, you can see that the patient revenue is £6 million adverse to budget. This is due to the patient revenue budget being set on 1920 levels of activity, which are not yet being achieved. And then the baseline payments are showing under plan, as they're based for now based on some contractual changes we've so far seen. However, this is still in lieu of the larger 23-24 performance adjustments that we will continue to monitor and then bring into the position as they crystallise. Secondary and community dental continue to be on plan. On page 9, there's still the off-ledger reconciliation of the dental reserves, which we introduced last month, that just shows the affordability of the investments which have already been agreed within the dental area. This will obviously be updated each month, but still continues to show that affordability at the moment. Sections 7 and 8 show the pharmacy and Optom areas, both on plan at the moment. And then section 9 is the efficiencies at the moment. This is updated for month 5 and shows a £1.6 million underachievement on the planned efficiencies. The two key areas being the opioid and pod schemes within prescribing being the two largest areas of slippage, where the rest are all predominantly on plan or overachieving. The unplanned closing the gap efficiencies, which were agreed in the last few months, have a budgeted £3.4 million worth of savings and are currently forecasting £2.4 million worth of achievement. The difference being due to the dental reserve, which will be crystallised further later in the year. The focus of efficiencies is probably now going to move on to what we'll be able to plan for 24-25. As our planning rounds now begin to start, and the ICB has submitted its medium-term financial plan and shared that with regional colleagues. And finally, the last section in the report is a summary of the LCS activity up to month 5, showing the areas where practices have claimed and haven't claimed, and the utilisation of that budget. So that was all the areas I was going to highlight, and if there was any questions at all.
Okay, well, while people are gathering their thoughts, I'm very sorry, but I just need to go back. So I think I heard you say that efficiencies have improved, and that the gap that was the efficiencies has narrowed. Is that right?
Yes, last month, absolutely. We identified more of our unidentified efficiencies.
Okay.
So yes, there was a difference between what we planned at the beginning of the year and we always had a section of unidentified efficiencies. That's what we've managed to identify to improve. And that's what those couple of sections are just trying to show what their achievement against the plan section and the achievement against the new closing the gap, as we've called them, efficiencies as well. And there is still a gap between the two of those, as in that they're not all completely to plan, but that's what we continue to monitor.
Okay. And as a layperson, where have those efficiencies come from?
They've come from meetings with the budget holders. So basically the closing the gap bit, the unplanned bit, if you like, that was part of a review at a budget line level, and the original planned ones were part of the planning round from last year, where we would meet with budget holders and ask them for areas where they could see efficiencies, essentially. So meds management is a key area for us, where we tend to see large areas of where we can look at drug switches to get efficiencies. So that tends to form the bulk of that for us within this area anyway.
Okay, all right, thank you. James, other James.
Yes, thank you very much indeed. You mentioned the dentistry and that the revenue was not equal to because it's based on the 1920
Yes.
figures. Is that because of lack of capacity to deliver that quantity, or is it lack of demand?
It's so the lack of access will contribute towards that. So absolutely. So the fact that we don't have the level of access from 1920 will push down that patient revenue, and the mix as well. So if for instance we're more children's appointments are offered, that will push down that patient revenue as well. So there are a couple of factors that do, but our budget was set on 1920 levels, which was our budgets were set by NHS England at the beginning of this year as we inherited these services. So that was something that we obviously had an issue with in terms of we didn't think that was going to be achievable, but they set those core budgets for us. So.
Right, so if I could just come back on that, then obviously it was to our benefit that was set on 1920, because that was a higher amount, and it's up to us to then try and achieve that. And I understand difficulties of perhaps not being able to, which means that we need to work harder to make sure we can commission it so that that activity can be achieved. So I'll just leave that one there and then going on to children, because that's my area. And so seeing on page 100, I think it is, a 9 of the report, it's got the children's pathway of 600,000 new scheme for 23-24. If that isn't all used in 23-24, will that be allowed to be carried forward?
So the funding source for that this year is based on the fact that we're anticipating access issues and underspend within dental this year. So that kind of general reserve reconciliation is trying to show that. That would disappear at the end of this year if it wasn't spent. But the likelihood next year is that we'll be in a similar position again, where we would have dental underspend. The value at which we're at the moment, I think, wouldn't mean that would disappear. So.
Thank you.
Karen.
Thank you, Debbie. James, just a quick question, and mine's dental as well. Where you've got the section, and I think it's on page 100, where you talk about there's a certain amount of risk and the value of potential clawback. I guess for me, from a quality and safety and delivery of service, really want to make sure if we are clawing back anything, that we are considering the viability of those practices, because it's quite obvious that some of those practices would fold because they haven't been able to deliver the activity due to a shortage of workforce. So just making sure that all of that is in the mix, because that would be the very worst of options if we then have an even worse provision of dental services. Thank you.
Completely agree. We're currently writing a policy at the moment on dental clawbacks, which tries to consider exactly that, because we understand the resilience issues, a number of other issues that would affect that, and we're trying to write a policy that will address those when considering the period of time for the clawback. So the standard at the moment, if we didn't have a policy, would be that BSA, who manage the payments, would simply claw that money back as quickly as they can. What we're trying to do is write a policy that says, let's consider the implications of that and the factors around the particular practice. So yes.
Fiona.
Thank you. I was just going to respond to some of those questions as well to support James. In terms of patient charge revenue, obviously that's collected from dental providers as they see patients who are paying patients. If practices are not seeing patients because they don't have the workforce to support that activity, then obviously we end up in that loop, that circle, whereby we don't have the workforce to improve access, and if we don't improve access, we don't improve the patient charge revenue. So that's why sorting out the dentistry challenges are complex and multifaceted, and we need to look at it from every angle. And obviously that's the aim of our short-term and obviously our long-term plans as well. In terms of children and young people, yes, we've put in place a short-term initiative for this year, but it has been identified as a priority for within our long-term plans, and you will see those schemes when we bring those plans to committee. And yes, again, in terms of the repayment model, the BSA standard approach is 3 months. We've agreed where practices have asked us to extend to 6 months, i.e. within this financial year, as a fairly standard response. And then, as James has indicated, we're looking at how we can support exceptional circumstances beyond that. And that's a little bit more challenging. But obviously we will be bringing that back to committee for discussion.
Okay, thank you. So I'm just going to be brave and ask this, what is probably a very silly question, but who claws back what?
In terms of the dental, yeah, absolutely. So the way it works is when a practice has an NHS contract, they agree to a set level of activity throughout the year, and they're paid for that level of activity in 12ths throughout the year.
Okay.
And then we claw back based on the under activity that they actually achieve after that financial year has finished, and that there are certain nuances around how near they get to that 100% achievement as well. So.
Right. Okay. And is that a rule, a national rule,
it's
an accounting rule?
No. It's the basis of the national sort of dental contract.
Yes.
Essentially.
Right.
Yeah. Okay.
All right. Okay. So maybe so just talk me through then, and I'm sorry that this is. So bear with me, I'm a local authority person, so immediately I see things in red that are good as opposed to bad, and all of that sort of stuff, so just bear with me. So what's the significance of the what you're saying in that dental reserve slide? I'm looking at slide 9.
So the dental reserve slide is basically saying at the bottom there that there is a significant amount of potential clawback that would come back, and that's what we're basing the investments on this year that have been agreed. That's kind of reflecting on last year, so we know the value which was clawed back last year when we weren't commissioning those services, and that access hasn't changed significantly from that point. Right. Obviously, those investments are aiming to change access to a degree as well. So,
right. Okay. All right. So in terms of your advice to us as a committee, I suppose, do you need us to do anything else about this? Do we continue to monitor it? Do we need to escalate it?
No, I think continue to monitor. I think absolutely would be the what I would say at the moment. Yeah.
Okay. Anybody else wanted to come in at this point? No. Okay. Sadie.
Sorry, I couldn't get my hand up quick enough.
That's all right.
I just wanted to confirm that, I mean, clearly we have a risk on the board assurance framework around the resilience of NHS dental services, and this is playing out in slide 9. And the issues that have been explained about the fact that if you're not generating patient charge revenue, then it's not there as part of your budget. So it essentially reduces your budget. So I think in terms of this committee, we continue to update the board through the board assurance framework risk on the resilience of dental services. We through you, Debbie, we report to every board meeting on the primary care committee in a similar way to the operational delivery groups reporting to this committee, and those risks are highlighted through that. So I think we are already trying to be as transparent as we can against the significant issues that we're trying to grapple with, and the fact that the short-term plan addresses some of this, and some of our longer-term commissioning intentions have been set out as part of that, with a clear commitment to publish a long-term plan in March. I think we're probably doing everything we can at this stage to monitor and highlight the issues that we're facing here.
Yeah. Okay. All right. That's helpful, Sadie. Thank you. Okay. Andrew.
Hi. Yeah, I just wanted to add that the 23-24 budget for dentistry should be ring-fenced, which means any money clawed back from practices shouldn't go back to NHS England. They should stay within the ICB funding for at least a year, which means we need to use all of it as much as we can, because if not, the following year it's going to disappear.
James is nodding. I'm hoping. Yeah.
Absolutely agree. Yeah.
Yeah. Okay. All right. Yeah. Thank you. Thanks, Andrew. Okay. So, thank you, James, for, really helpful sort of run through of that. And thank you for picking up the sort of clarification and explaining it in that way. It's really helpful. Okay, so I think we note this. I don't think there's anything for us to agree, but recognizing what Sadie says about actually putting this in front of the board as one of the risks, and in the report we do, I'm quite sure we would want to draw attention to this, just to keep it on that agenda. Okay. Okay, so I think that brings us to the end, and I don't think we've had any public questions this time, Sadie and Sarah. No. Okay.
I don't know if anybody would like to ask one, but we haven't had any sent through in advance.
No. Okay, all right. So in that case, so a reminder that we're not meeting in November. So the next one for us is the 12th of December, which is a bit scary, isn't it? Yeah. Okay. All right. Well, thank you very much, everybody, for your contributions. Thank you for the high quality of the papers and the inputs. Really, really valuable. Thank you. All right then. Bye-bye.